The Norman and Florence Brody Family Foundation is dedicated to exploring topics of national and international importance and is proud to support Policy Watch with Doug Besheroff at the University of Maryland. From the University of Maryland, this is Policy Watch with Doug Besheroff.
Healthcare spending in the United States has been growing for decades and is now nearly a fifth of all economic activity, significantly higher than what other developed countries spend. While many argue that this high level of spending is essential to maintaining America's international leadership in medical treatment and pharmaceuticals, others claim that Americans overspend on healthcare services, often on treatments that are not entirely necessary. Most agree, however, on the need to at least slow down the growth in spending, particularly the government's growing obligations to Medicare and Medicaid. Joining us to discuss healthcare spending in the U.S. is Robert Reischauer, president of the Urban Institute and former director of the Congressional Budget Office. And now the host of Policy Watch, Doug Besheroff.
Bob Reischauer, welcome back to the University of Maryland and Policy Watch.
Pleased to be here.
Let's talk about healthcare reform and the future of Medicare. You're not only the president of the Urban Institute, you were the director of the Congressional Budget Office in the 90s. You've watched, looked, studied these problems for many years. I suppose the first question is, why do people think we are spending too much on healthcare? Why do people think we will spend too much in the future? Why is healthcare such a worrisome matter for Americans?
Well, healthcare is about 16% of our economy, so it's a big chunk of what we're spending money on. And unlike almost everything else we buy, we aren't making the same kind of decisions when we buy healthcare. We're getting it through insurance that's provided through an employer usually, or through a government program. When we buy food, when we buy a house, when we buy a car, when we go on a vacation, we're taking our own wallets out and we're saying, how much do I want to spend on this vacation? Is it worth it? We buy healthcare sort of collectively, and we don't have often a lot of choice. I mean, I get the insurance that my organization provides. I don't really have any other choice. And then once I have it, I can use it as often as I want. And while I have to pay a copay or I have to pay a deductible, I'm not paying the whole thing. I'm paying a very tiny fraction of what I'm buying, and it's like buying everything at a discount. So I will overconsume probably healthcare, and there is a feeling that we as a nation are probably consuming more than is optimal, than we would like to. We look around the world and we say, you know, we're spending 17% of our GDP on healthcare, and you know, other countries that are as healthy, the people are more satisfied often with the health care they get, are spending 9, 10, 11% of their GDP. What could we do if we had that chunk of money to spend on other things? And that's why people are concerned about it.
I know we're going to talk about the real world, but if you were reconstructing the way the world operated, you could build an insurance system that would avoid this problem?
Well, insurance is, when we come to health, you really have to have some kind of mechanism for insurance, because the minority of people who have a serious health problem, most people are healthy most of the time, but at times people aren't healthy, and when they aren't healthy, all but the super, super rich couldn't afford the care that we provide or any other nation provides. So you have to have some mechanism for doing this. But then you want to make sure that there's a set of incentives through which providers provide and patients seek efficient care, parsimonious care, and we don't have that now.
The Republicans, or some people on the Hill at least, seem to think that we could do better with a form of insurance that's more like catastrophic care, so that first dollar coverage would be the responsibility of the patient, and I think sometimes this is called insurable events versus just ordinary medical care. What would a world like that look like?
In theory, there's nothing wrong with that kind of world, but if you think about what's insurable, what do we regard insurable as insurable for individual who has income of $500,000 and somebody who has an income of $10,000, they're very different things. And so your sort of what you pay out of pocket would have to vary by the individual circumstances, and that would be horrendously complex to do.
So the Obama administration now comes into office and says, reform health care. Campaign was largely or substantially run on that. And it has had a great deal of difficulty. And I think you've written that part of the problem is it's a multi-dimensional set of objectives that they are trying to achieve at the same time. Access, cost control, and quality. Talk a little bit about that.
We're worried about access because 17% of our population is uninsured, and when something happens to them, they go to the providers, and we don't deny them health care. We provide it, and somehow that's paid for largely by all of us, indirectly. Another substantial chunk of our population has inadequate health care, health protection, huge deductibles, exclusions for certain dread diseases, and just something that none of us in this room would regard as adequate health care insurance. So doing something about that is a moral issue, really. But it's also a practical issue, because unless everybody is sort of in the system and covered, it's very hard to restructure the system or put any kind of rational policies in place that might dampen the growth of healthcare spending, because you don't want all of it to play out on the most vulnerable and disadvantaged of our society. And thirdly, while we are very fond of saying, we have the best health care in the world, the fact of the matter is, if you look at the international studies, we don't. On a lot of dimensions, countries in Western Europe do a better job. There's some things we do quite well, and we're at the top of the heap, but we don't stand out at all, and on lots of things that we pride ourselves in. How long does it take to get to a doctor's appointment when you have something wrong? Well, you find out in half the countries in Europe, they wait much less time than we do. We can improve the quality just very significantly.
I've read that the cost variations, the use of different procedures, especially diagnostic procedures, varies widely from place to place.
Well, if you just look at sort of metropolitan areas in the United States and you wash out differences in prices, and all you're asking about is service use, how many sort of things do they do per Medicare beneficiary. And the national average is 100, and you will find in the Miami metropolitan area, they do 39% above the average. And in Lubbock, Texas, they do 127%, or 27% above the average. And in many, many places, Portland, Oregon, Minneapolis, they do 18% below. So you're talking about sort of 50%, 40 to 50% more things are done to the average Medicare beneficiary in Miami than in Minneapolis. But then you look at the outcomes. You know, are the people in Miami a whole lot healthier? I mean, are they adjusting for their age and their chronic conditions, everything? The answer is no. And to the extent that we have any evidence, it suggests that the people in those areas where the care is rather parsimonious are actually better off.
So in many parts of the country, physicians and hospitals say they're already, hurting is a strange word, but there are many physicians that no longer take Medicare patients. In this community, there are hospitals that are not taking Medicare patients for certain kinds of procedures and departments. They're just not doing it. So,
well, I mean, if you take them, if you take Medicare, you have to take them for everything you do. But
I won't name names,
we
but
won't get into
I won't name names.
Medicare pays in general below what private insurers pay in most of the country. Medicaid pays below Medicare, and so there's been sort of a lot of discussion in private insurance companies that we're subsidizing, private insurers are subsidizing Medicare and Medicaid. It's a very complicated argument on whether we should be worried about that or not. There is concern that if we cut back the payments that Medicare is making over a long period of time to providers, that Medicare beneficiaries might face increased access problems. More doctors will say, I don't want to treat Medicare patients. More hospitals will say, we're not doing Medicare at all. It's something which you certainly should, keep your eye on. My guess is that should Medicare begin cutting back the growth of its annual updates, private insurers will do the same thing. And so the relative attractiveness of private versus Medicare payments won't be affected that much. But one doesn't know. I served 9 years on something called the Medicare Payment Advisory Commission, which is a congressional permanent commission that advises Congress on Medicare policy, and I was the vice chair for 8 of those years. Every year we did a survey among elderly and disabled people and among physicians, and said, are you taking new Medicare patients? Are you taking only patients that you had before they turned Medicare eligible and all of that? And there wasn't any diminution over the last 9 years in access. I mean, it was still very high, up in the mid-90%. But this is the kind of thing that can change very rapidly, and you want to be very, very careful on that score.
But I interrupted you with your list of other changes we could expect.
Okay, so one is cutting payments, and a big chunk of the savings is going to come out of Medicare Advantage plans, which are these private plans. You can get your Medicare through one of 2 flavors. One is the fee-for-service system, which probably many of you are in, traditional Medicare, or you can have Medicare buy you coverage through Aetna or through Kaiser or somebody else, and they provide a big package of services, the same as you get otherwise. The payment system is a little screwed up, to put it mildly, technical term, and we end up paying about 14% more to those private plans than it would cost the government to cover those people if they were in the fee-for-service system. And so one of the savings in these bills is let's cut that back.
I don't know whether it's 14%, but the people in those plans get a little bit more.
Oh, yeah, no,
they get more.
They get more.
So it's a cut in benefits.
Absolutely. For
I'm
them.
not saying we shouldn't. I'm just saying it is a real cut.
We're paying more for them, and because we're paying more for them, everybody else's Part B premiums goes up.
Right.
Okay, so that's one thing we're doing. The second thing these bills do is they expand some benefits for Medicare participants. They increase the generosity of the Part D drug benefit, filling either completely or partially the donut hole where people are uncovered. They provide more in the way of preventive services and lower co-payments or deductibles associated with certain preventive services. So that's the second thing these bills do. One is it affects providers. The second is there's a big benefit for participants in the program. And the third thing these bills do is they start up a lot of demonstrations and pilot programs to test new ways of delivering services or new ways of generating different provider structures like accountable care organizations and things that we feel might be able to provide care more efficiently than individual doctors in small practices spread out across the country.
What are some of those demonstrations, do you know? Is it fair to ask?
Well, there's one with respect to accountable care organizations. There's also an effort to do what's called bundling, which is a different way of paying for services. Right now, you go into the hospital, a diagnosis is made in one of several thousand diagnoses, and the hospital gets a flat amount of money for providing those services, whether you're there 2 days or 6 days, and the doctor's fees are separate. Bundling is the idea that you take an episode, chronic condition treatment for a heart problem of a certain kind, and the hospital gets a chunk of money out of which the doctor is paid, the hospital is paid, and the post-acute care entity is paid, the nursing home, the home health care agency, whatever takes care of you. So we're looking at the whole package that goes together, and rather than paying piecemeal, we're giving...
So this is like a big DRG.
A big DRG that extends beyond the particular institution. And the hope is that that will create incentives for the care to be coordinated. Problem right now is care is delivered in a fragmented way and is totally uncoordinated. So you walk out of the hospital in some hospitals and there isn't the kind of coordination with the post-acute care entity. There isn't the phone call home saying, are you taking your medications or how do you feel? We want you to have this whole experience done in an efficient and effective way.
Anything else we should look for?
I would say that there shouldn't be a lot of worry about what is being proposed in these bills. But the most important sort of message that I'd like to get across is solving Medicare's problems can't be done within Medicare. We need to change the way health care is delivered and paid for in the society as a whole, because we don't have a Veterans Administration or an Indian Health Service for elderly and disabled. We don't have a separate delivery system. All of us are in the same delivery system, whether we're 18 years old, 8 years old, or 85 years old. And so you can't sort of make a lot of changes within Medicare because the services are being delivered by the broader healthcare system. So we have to change the incentives in the broader healthcare system if we're going to, in a way that allows for cost savings, if we're going to solve Medicare's problems.
And that's what makes solving Medicare's problems so difficult, and that's what makes doing healthcare reform so difficult, because there are loads of vested interests involved in all this, besides just the patients.
Right, and the structure we have now is a huge economic component of many local areas. And, you know, one man's inefficiency is another man's income. And you saying, I'm going to consolidate this and do it in a more efficient way is threatening.
Well, I think it's time for us to turn to our audience for some questions. Bob Reischauer, thank you very much. And now we'll turn to the audience for questions for our guest, Bob Reischauer.
My name is John Murtaugh. Budget question. We hear so much about homeowners getting in trouble because interest rates go up. The biggest borrower I know is the federal government. What's going to happen when they start raising the interest rates? We're told that this is coming and that the Federal Reserve has it in the game plan to slow things down by raising interest rates. Isn't that going to be a budget buster?
This is a great topic to bring up and a good question. We have begun to borrow huge sums of money, and interestingly enough, the interest costs for doing this, despite the fact that our debt is soaring, are lower now than they were 2 years ago. And it's because there's been uncertainty in the world and a flight to quality and liquidity, which means to U.S. government securities, because the stock market's fallen apart and things like that. And we're living in a unreal world right now, where we're demanding more of something, and instead of prices going up, the price has been going down. Interest rates been going down. Built into all of these forecasts of future budgets are assumptions that interest rates are going to rise. But it's really quite a controlled rise. And what scares me is that the increase could be a lot faster. And it's not going to be as a result of the Fed changing gears and beginning to rein in its actions. It's going to be related to the same things that are driving up borrowing costs for Greece, an unwillingness of foreign borrowers, foreign lenders, to provide us with money at low interest rates. But I think it's a huge danger.
Thank you for coming, and ask you a question. How is it that in this era of no trust in anybody, the CBO, yours, manages to be the ultimate to believe in? Where does the trust come from, and why is it nowhere else? How can we get some of it back?
It comes from being strictly nonpartisan. It comes from having a extremely talented and hardworking staff. It comes from the standards that its first director, Alice Rivlin, established. And it comes in part from everybody in Congress being angry at it some of the time.
Janet Lowenthal. I'm heartened that you are quite optimistic, or somewhat optimistic, about the improvements that we may see coming down the line over the next, say, 5 years, due to things like comparative efficiency studies. And these improvements in efficiency also mean reductions in people's incomes. And I'm wondering how politically feasible you think it will be to maintain a sort of positive trajectory moving further and further down the line in increasing efficiencies as people's incomes are being, people's oxes are being gored by the very processes that we hope to encourage.
I take hope from the fact that I think if we continue on our current path, we're going to have a significant shortage of providers. It's very hard for the government to impose these kinds of changes, because then it really does come down to, that's my job, that's my hospital. But these things play themselves out in local areas. And there are a lot of very talented health professionals who are working hard to make changes. And there's some changes going on in Massachusetts, in Vermont, in Wisconsin, and other places that are really could take off at this point. And that's why I'm mildly optimistic.
Well, on that mildly optimistic note, let me thank Bob Reischauer again. Let me also thank Florence Brody and the Brody family for supporting these events. And we have this little tradition. Bob and I have been drinking from these cups, and they say Brody Forum and University of Maryland School of Public Policy. So, Bob, as they do at the National Press Club, thank you very much. It's been a great program.
This program was produced by the University of Maryland, which is solely responsible for its content.
The Norman and Florence Brody Family Foundation is dedicated to exploring topics of national and international importance and is proud to support Policy Watch with Doug Besheroff at the University of Maryland.
We are PBS.